So good day, friends. This is Dr. Bob Hamilton, and you have tuned in today to the Hamilton Review, where kids and culture collide. Before we begin the show today, I'd like to say thank you. Thank you to all of you for tuning in. It means a lot to me. I thank you for that. And my job, and I try to do the best I can, is to bring before everyone on a weekly basis amazing people, people who are doing things which are remarkable and are challenging, actually, mentally, intellectually challenging. And today is no exception. If you like what you hear, I ask that you pass it on to friends and family. I'm doing my very, very best to build a listenership, and not for me, but for the people who like bring on the show. So thank you very much again for tuning in. And with that being said, I'd like to introduce our guest today. Her name is Dr. Sabine Hazan. She is a gastroenterologist. She has a particular interest in what we call the microbiome. We're going to talk about that in a second. But Dr. Hazan, welcome to the Hamilton Review.
Thank you, and thank you for having me. You're catching me at a day where my voice is a little bit on the rough side, losing it, screaming too much, I think.
That's okay. Well, you know what? No problem. I can hear you perfectly clearly.
Perfect.
I think this will be I don't think it will make an effect in our conversation at all.
Good.
So, Dr. Hassan, what I like to do with my guests is I like to back up in their life and start a little, tell us a little about who you are, where you're from, your story, and maybe a little bit about how you got involved doing what you're doing today. So, with that, I'm going to turn the microphone over to you and let you take it from there.
So I started as a gastroenterologist, as the first woman at University of Florida. It's been a road of challenges. My life, I think, is best described. You were praying before, and when we talk to God, you kind of see God bringing you on a path. And really, this whole path is divine intervention. And I'm going to start with that because when I was 5 years old, I asked God, where do we go after we die? And He brought me in this path. But along the path, He trained me. He trained me by, when you fail and you fall at the bottom of the pit, you have to stand up quickly. So when you fail, and you realize you're not getting to your next step, you have to like figure out a different way to go to the next step, right? So my whole life has been wanting to understand, where do we go after we die? Medicine was the first step to doing that. So it was challenging to get into medical school. Then it was challenging to get, I was challenged because someone said, we don't take women in GI. So I said, well, I'll be your first woman. And so that was the next challenge that I took on. And then surviving as a woman in GI in a world where it was mostly dominated by men. When I started, there were maybe a dozen of us women gastroenterologists in the field. So we didn't really have a voice at the time. And you had to work for these academic centers. So to be outside the academic center in a private world where I'm competing, as a woman, it was very challenging. And that was, those were roadblocks. And of course, that brought on more challenges. And then, it's one thing after another. Like you do clinical, you can't stay married to a cardiologist and be a GI doctor. Well, I'm married 30 years. You can't do clinical research and do GI. Well, here I've been doing both for 30 years. So it was all these challenges that basically I took on one by one. And then what happened was I went into clinical research because medicine wasn't fulfilling enough. I was not treating my patients. I was not figuring out a solution for them. I'm not a girl that likes to take pills. So, you know, I don't like my patients having to see me as a doctor continuously on a month to month and not being able to fix them. I like to see my patients and then get rid of them because I know as a doctor myself, I don't like to see doctors. I don't have time for it. I'm busy. So it's like, give me that pill, fix me so I can go back to doing what I'm passionate about, right? So clinical trials was really a different way for me. It was a way to see to see what else is out there, in for Crohn's. What else is out there for, ulcerative colitis, ulcers. It was always being ahead of the curve. And when clinical trials became a fecal material pill, one could say I went rogue. And I basically said, what are we doing here? Yeah.
Yeah.
And then
So so
and then
let
I
me
started looking into the microbiome. And again, I was challenged because those that were looking at the microbiome said, there's nothing for you to look at. We've already looked at it. So I
yeah.
said, two guys with two sets of eyes looked at trillions of bugs and they figured it. Okay, fine. And so here we are.
So let me kind of back up a little bit. So first of all, so you found you have overcome a lot of obstacles. By the way, you did mention that you're Canadian. You went to medical school in Canada, and you found your way into an American training program in University of Florida. And you have become a gastroenterologist. And by the way, bravo! I'm glad you fought and you overcame those obstacles. I find the people who overcome obstacles are usually um, innovators, and entrepreneurial because they have to keep pushing. They're obviously driven, and
Yes,
that
yes,
is
yes.
very evident in your life. So you ended up getting in. So what you're saying is that you were treating people who had ulcerative colitis, Crohn's disease, and a myriad of other types of GI symptoms, but you felt frustrated. Is that where
Yes,
you is that
yes,
the right word?
yes,
Okay.
yes.
So take it from there. You were frustrated and you began to look at the microbiome. Now, why did your eyes kind of shift over to the microbiome? And first of all, maybe explain, Sabine, what the microbiome is, and why
Yes.
is this becoming such an important um, issue in the medical world today?
So the microbiome is really all the microbes that are around us on our skin, in our bodies, in our mouths, in our nose, everywhere, right? And the microbiome of the gut, what we look at as our stools, is really trillions of microbes doing something in order for us to function. Think about a bacteria that helps you absorb sugar. Think about a bacteria that helps you absorb calcium. Think about a bacteria that helps you, your mood, your happiness, right? This is what these microbes in our guts are doing. It's like that transmission of a car, that without the transmission, you cannot drive the car. What most people don't know is the transmission of a car, when you open it, it looks like a solid piece, but when you open it, it's actually 880 pieces. If you break one piece of the transmission, the whole transmission's broken. So
Yeah,
are you gonna fix that piece or are you gonna change the whole transmission? You're gonna change the whole transmission. That's what the microbiome is. It's that solid poop that you've taken on some antibiotics and now you're killing a bunch of microbes. Now you're taking on some drugs. Now you're killing some more microbes. You're drinking that drink that's not really good for you. You're killing more microbes. Your transmission, that solid bowel movement you see in the toilet, is really gone. It's broken. And so fecal transplant is the process of taking a new transmission from a healthy donor into an unhealthy donor. The problem is, much like a transmission of a car, you have different transmissions. And those different transmissions, it may not be compatible. Am I going to put a transmission of a Mercedes into a Honda? No, it's not compatible. That's what we are in the microbiome space.
yeah. Okay,
So
so when okay, so you're talking about fecal transplant now, and just to kind of break this down, what you're doing, and I'll kind of put it in plain English, is you're taking the poo of one person who's a healthy person and has not been taking antibiotics, has been living a good clean life. They're not smokers or drinkers, or I mean, I'm sure you screen for all this in your donors, and you're putting their poo into the body of a person who's ailing. Is that, and how do you? Let me tell you, I'm it's actually the lunch hour for me right now, and this concept is a little bit kind of decreases my appetite. We'll put it that way. So, what can you
It decreases.
explain? Can you give me a little bit of a background on what you're talking about? Because I'm not confused, but I'd like you in your words. What are you doing?
I'm literally taking stools from a healthy donor. I'm processing it, so it's mostly microbes, and I'm putting it into the colon of an unhealthy person with C. diff. So C. diff is a bacteria we get because we've damaged our microbiome and we get diarrhea.
Yeah.
That person that has C. diff, even though you tried giving them antibiotics, flagyl, vancomycin, fidaxomicin, they still come back to you with C. diff. Why? Because you keep killing the microbes. You're not fixing the problem, which is reestablishing the microbiome. So the idea with C. diff comes with you're looking at C. diff, you're killing groups of microbes, you keep killing, and then the patient's still sick. Why? Because he no longer has microbes to sustain himself. So the answer was taking stools from a healthy donor to put it in there because you're restoring that diversity. Now with C. diff, it's very easy.
So
Can
you're basically recolonizing
correct.
the colon. Okay, is that correct? And you do this by putting the poo into a pill. Is pill form? Is that correct, or how do you actually do that?
Put it in a pill form. You could do it via rectal enema. You could do it via colonoscopy. You could do it via NG tube. Any way you put that poop in there, you're recolonizing the colon.
Okay.
Yes.
And so when you do this, so what you're saying is that, I mean, C. diff is one of these bacteria. Sorry, I have a siren going by. I apologize.
Right.
But when you have I mean, C. diff is one of these bacteria which we all in medicine we do not like because it causes a lot of problems with with pediatrics as well. And obviously, friends, when we as doctors give antibiotics, one of the things we worry about, especially when you have a person who needs antibiotics, if they have some kind of a bone infection, for example, or meningitis, something significant where they definitely need antibiotics, we do worry about killing off the good bacteria. And I mean, we don't. I recommend, and you'll probably agree with this. When I give antibiotics, I recommend that people always take a probiotic to ameliorate and maybe help to replete some of the bacteria we're killing. Um, how when you get to fecal transplantation, which is what you're doing here, when does that? I mean, I don't give a fecal transplantation every time a kid gets an antibiotic. I don't think anybody would be giving their kids antibiotics if that was the case. But tell us when that need arises.
The need arises when you have through two cases. Well, that's the guidelines, anyways. When you have two cases of C. diff, then you do fecal transplant. Dr. Barodi and I, who have been, kind of doing fecal transplant for many years,
Yeah.
we feel that it should be done probably the first time you have C. diff, because the problem is you need to restore the microbes, and it's not just one; it's multitude of microbes. So I feel personally that you should do it from the first one, but the guidelines is really if the second time you have C. diff, then you're able to do fecal transplant. Here are the challenges of fecal transplant. It's not easy to find a donor. Don't know what we are swapping C. diff for, right? What brought this field to where it's at now is really the fact that um, doctors were basically seeing other things when they did fecal transplant. Dr. Sahil Khanna at Mayo Clinic saw chronic urinary tract infections improving. My own case, one case of Alzheimer's improved with fecal transplant. The guy had C. diff, but he also had Alzheimer's, but his Alzheimer's improved.
Oh,
That was the beginning for me. That was the first case that made me ask, what did I do when I changed the microbiome? And then, of course, I'm the kind of girl that continues the inquisition, right? So continues asking questions. So I
yeah.
called my friend Neil Stolman. I said, do you think that's weird? I mean, I had a guy improve. He remembers his daughter's date of birth with fecal transplant. And Neil said, have you seen the cases of Colleen Kelly of two patients with alopecia areata growing hair? And
Wow.
that really took me to the next level, right? Because it was like, what grows hair in the microbiome? What microbe is responsible for growing hair? Now, the problem is that the same two people that are improving with fecal transplant, there's another two people that got alopecia areata from fecal transplant, right?
Mm, yeah.
We're not at the level of saying to patients, look, I'm giving you fecal material, but I don't know if you're going to be bipolar from this, because what we're seeing is bipolar disorders in the microbiome. We're seeing a signature, we're seeing something, some noise of in the microbiome of something that's bipolar. We certainly are seeing with anxiety
Yeah.
a signature microbiome, right? So when you see that, you have to say, is it the microbes that are increasing because the person's anxious? Or is it that they acquired these microbes and therefore became anxious, right? So there's a million questions that come
Yeah.
on all day long, every day in my mind. So this transition, this path going from clinical trials for pharma to really taking it to the microbiome level is really what I embarked on because I wanted answers. And I really felt like we cannot advance medicine until we understand the microbiome better.
Yeah.
Because, yes, we could sell fecal material in capsules. I could come out tomorrow with my favorite probiotic, put my face on it, and sell $1 billion worth of probiotics. But is that going to advance mankind? Is that going to advance the science? No. We need to understand methodically the microbiome. We need to see when we reach a cure, what changed in the microbiome. When we look at patients with anxiety, what is going on there? Take a history, do a physical, look at their microbiome, look at their blood, put it all together.
Yeah. Okay. So I want to talk about that because in my world in pediatrics, we're dealing with a lot of kids right now who have anxiety, and obviously in the adult world as well. You're an adult doctor. Tell us a little bit about this anxiety syndrome, and and maybe some of the details about what particular bacteria are you finding in the microbiome, because you're relating anxiety to the bacteria in the GI tract. Now, let me just say this, that I kind of go, really? I mean, this is new information, I think, for a lot of people, and
Yeah.
you're on the cutting edge of this. So can you elucidate that for us?
I'm going to take you back to COVID. Okay. We were the lab that
Please don't do that. I'm
just,
trying
just
to
a little
COVID.
bit, just a little bit.
Okay.
We were the lab that found COVID in the stools. Okay. In 100% of patients that had positive nasal swabs, they had COVID in their stools. From there, we looked at the microbiome of those patients with COVID to see what's the difference between severe COVID patients versus non severe patients. Okay. And what we discovered was that the non severe and the people that never had COVID but were exposed to COVID had a lot of bifidobacteria. The people with severe COVID had zero bifidobacteria. Okay. So why bifidobacteria? Because if you look at the microbiome of aging, you start with a lot of bifidobacteria as a newborn, you die with zero. Okay. So the process of aging is loss of bifidobacteria. So that's a very important microbe. Okay. That's number one.
Yeah.
Number two, it's your $1 trillion industry of probiotics. So they know something you don't. Remember, The businessmen always are developing something, but they're not gonna tell the doctors. They're gonna keep it secret. And then they're gonna start advancing, and then they're gonna sell you through guidelines, right? That's how medicine is working these days. So if you look at probiotics,
Mhm.
why were they created? Because there was a discovery that with loss of immunity comes loss of bifidobacteria. Saying that I proved during COVID, severe COVID patients, zero BIF. High risk, exposed, never got COVID, high BIF. Okay.
Okay.
Now, obviously, your bifidobacteria goes up, down, on a daily basis, even within the same day. But there is a moment in time where you could see the depth of the microbiome. And that's what we do. We look at the depth of the microbiome in that moment in time. We normalize it to say, okay, well, this is what appears to be the level of bifidobacteria in that patient. Okay.
Yeah.
So when you see 40 or 100, 200 patients with severe COVID, or even these long haulers or vaccine injured, they have zero bifidobacteria. When you look at a health population that never got COVID, they have a high bifidobacteria.
Yeah.
So it continues. It's not like 40, 70, it's hundreds, okay? Because I have probably the biggest database of unvaccinated patients who have survived not having COVID. So they have a lot of bifidobacteria. So bifidobacteria became the focus for me because I was working on a protocol of fecal transplant for autism. Remember, autism is in some kids a gut dysbiosis. I think we've proved it. Dr. Adams proved it. A lot of people have proved that there's a gut dysbiosis. Sidney Feingold, from the beginning, Dr. Feingold was the one who wrote the book on anaerobic infections,
Yeah.
said autism is a gut dysbiosis. Okay.
So hold on. So Sidney Feingold said that autism was a dysbiosis.
Dysbiosis of the
Really?
microbiome.
And I mean, because he wrote that. I mean, that was years ago, many years ago, right?
He wrote a hypothesis that he wrote a paper. He wrote a bunch of papers that he never published. It was controversial at the time, and he wanted to keep his tenure with the VA and also keep his grants and keep his, like everybody,
Yeah. Yeah.
unfortunately,
Yeah.
you're limited with what you can write. I'm in a different position because I don't work for anybody. So I can write whatever I want, but I'm going to get some slack on it. But guess what? That's how you advance science. It's controversial. Science is controversial. You have to ask questions, right? I mean, if we can't ask questions in science, is it even science? If we follow a narrative, is it science? No, it's propaganda.
Well,
So
you know what? So I have to tell you, let me interject. I'm beginning to wonder if we're losing science because we're not asking some of the questions. So let me ask you a question. You're talking about autism and dysbiosis. You are in the business of the microbiome. Have you actually tried uh, fecal transplantations in children who have autism, and what has been the outcome of that?
So we had one case. It took us 3 years because COVID was in the middle of it.
Yeah.
And it took us 3 years to get that case approved. And we finally did it. And the kid improved. He started speaking. His microbiome matched his sister's. So therefore, there was a process of engraftment that we like to call. He went to prom with a girl. He's doing great. Does he need more fecal transplant? Absolutely. I think, you know, we were under the FDA supervision, so we could only do three. But I think these kids, because he was so old already, he was like 19, to catch up on the 19 years of microbes that he's lost, needed more microbiome, more transplant. So it's a beginning. It's a beginning to see the kid is speaking. He's verbally communicating by keyboard. So he's changed the vocal for the keyboard, but he's communicating. It's no longer aggressive. He's no longer banging his head on the wall. He's no longer breaking his teeth. That was the big thing with this case. That's why I took it on.
So
But
when
there's
at what age did you begin the fecal transplantation?
19, he was 19.
19. So he had lived 19 years. in the state of, was he, you would consider him a significant autistic because there's a spectrum. He was, yeah. Okay.
Yeah, and the family was basically the family unfortunately had to take turns at sleeping. Like the mom would stay up one night, the father would stay up another night. It was difficult because they couldn't leave him alone. They were afraid he would pick up the toilet and like, break it or something. You know what I mean? He was that strong too. He was 6 foot tall.
Yeah.
So this was a very hard case. And the fact that he's soft now, non-aggressive, communicating, even if it's on a keyboard, it's unbelievable. And also his microbiome is still growing the same way to catch up to his sister. So that was the first case. Now we're trying to get 30 more cases by the FDA.
Yeah.
It's difficult because it's not a pharmaceutical product. The FDA wants pharmaceutical products because they support the industry, right? And those are coming, right? But they're coming faster than the science. And here's the problem with advancing technology that's faster than the science is we're mixing up everything. And then we're going to go back and say, shoot, we shouldn't have used this microbe in these kids. You know,
Yeah.
it's a we need to advance together.
So, when, if you could, with a child who's manifesting signs of autism, say, they're, I mean, some of these kids are relatively young, 4, 5, 6 years of age, and you know that. Would you recommend, would you just recommend doing a fecal transplantation straight up, or is that allowable?
No, I think we're not there yet. We're
Yeah.
not there. We have to be cautious, and especially because a lot of these kids, it may not be a microbiome problem. There's kids that I'm seeing, sibling with sibling and the mother. So what I do in my lab is basically I analyze the kids, the sibling, and the mom.
Okay.
And then I see what does the mom have that she gave her two kids, and also the dad, frankly, because the dad gives microbes as well. And then what is the kid with autism missing? And what does he have that's overgrown, right? And does the sibling that's neurotypical have it? Then bam, that's my protocol. If that fits into that protocol, in other words, I had a case of triplets. Two of the triplets were neurotypical, and the one kid was autistic. Okay.
Yeah.
And he noticed an overgrowth of a certain microbe that the mom had. So probably you could think about maybe she gave too much of the bad microbe to the third one, and then the other two um didn't they had enough diversity. They had enough.
Yeah.
So to the neurotypical with a diversity, I would totally use on my triplet, right? So that fits my protocol of
Yeah.
familial fecal transplant. The problem is, and as Dr. Feingold isolated it, is a lot of these kids have the same microbes because they live in the same family. So one could become resilient to the microbes, but you don't necessarily want to give that microbiome to the other kid if he's got microbes that are already causing the problem, right? So
Yeah.
that's why an investigation of the microbiome at a deep sequencing, which is what we do at Progenibiome, is important because you need to fine tune these kids. And then you have these kids that look exactly the same. They look the same as the mom. They look the same as the neurotypical kid. And those kids, it's either brain primary or connection between the brain and the gut primary. And this is the mistake we make in medicine in general, right? We always think it's, oh, autism is caused by one thing. No, it could be caused by multiple things. It
Yeah.
could be caused by metals. It could be caused by toxins. It could be caused by a neurological primary, a brain to gut primary, a microbiome dysbiosis. And then in the microbiome dysbiosis, which microbe is the problem, because you have to
Yeah.
find the microbe, kill the microbe, and then restore the colony, right? So it's not very easy, it's complex. But that field started me on all this, right?
Yeah, no, I mean, I think that, listen, if you can shed light on autism in any way at all, you're worthy of a Nobel Prize because this is something that has eluded people for a long time. I'm watching our time here. I have a couple other important questions I want to
Yes.
ask you. Number one, we talk in my world in newborn babies world. We talk about vaginal transplants and basically what more and more babies who are not delivered vaginally but instead are delivered by C-section. There's this idea of taking a swab, putting it into the vagina, and then putting that into the mouth of the child, washing, kind of putting it on the skin. Actually, can you speak to that a little bit about what in this world that I live in we call vaginal transplants? Do you agree with that, and why are they important?
I think they are important because they're exposing the baby to microbes so that the baby start building up their immunity right away. Um, But you gotta be careful. Obviously, I wouldn't swab a vagina if there's herpes in there or if there's HPV in there. So you gotta take a history of the mom before doing that. But if it's a health mom who's, had a good, a good vaginal flora, doesn't have yeast infection, doesn't have herpes, doesn't have HPV, yeah, I feel perfectly comfortable with doing that.
So you recommend that? Yeah, I mean that is being recommended, and we are doing some of the OBs in the community are doing that. Not everybody. If they don't do that, do you recommend giving probiotics to children to newborns immediately?
No, I don't. I don't. Because I think most kids are resilient and they build up their own microbiome. Um, so I would leave them grow. What I would do is give them vitamins at least to sustain the stressors of the C-section. So probably some vitamin D, making sure. I think we undermine the value of vitamin D. I
Yeah.
think there's a role for vitamin D in the pregnancy. There's a role of vitamin D in the delivery. I think that's more important. Exposing the baby to sun, oxygen, good food, breastfeeding is very important. Decreasing the stress of the mom, because if the mom is stressed, the baby's not going to get a quality milk to grow. So to me, it's more important for the baby to grow naturally. My concern with all these probiotics on the market is that they are suppressing the ability of babies to develop their own, to
Hmm.
make think about what we do with pancreatitis, right? Or people with pancreatic problem, right? We give them pancreatic enzymes, right? But we're suppressing the ability of their pancreas to work, right? So imagine the people that don't have a pancreatic problem and now they're taking digestive enzymes. You're suppressing your own ability to make pancreatic enzymes, and then you get yourself into a bigger problem down the road. Same thing with laxatives. If you give a woman laxatives, but colon's not gonna work. It's saying, well, why do I need to work? She's going to give me laxatives, right?
Yeah.
So I think we need to stay away from, we need to let the body do what the body's supposed to do, which is create an immune response.
So what
Create,
about kids who have colic? I mean, I have kids who are colicky,
yeah,
and
that's
the
actually,
recommendation out there is that probiotics are one of the things that we use for colic. Is that something that you agree with or not?
if they're colicky, they're missing some microbes, then yes, possibly you could try that. Okay. But don't use it long term. Let them pick up on their own.
Yeah.
Uh, so but then you got to wonder why they're colicky, right? What is in the environment that's making them colicky? Again, are they vitamin D deficient? So is the mom vitamin D deficient? So I think, nutritionally, is are they getting the right foods, the right, intake?
Okay. Another question for you. I recently heard that Parkinson's disease may be related to a dysbiosis in the GI tract. That to me, when I think about Parkinson's, I think about the substantia nigra and loss of the cells there. And tell me about what you know about that relationship.
We published actually about 4 years ago at the American College of Gastro an abstract on Parkinson's being a gut dysbiosis problem. And I'm going to stick to that it is a gut dysbiosis. It If you look at the studies, the problems with Parkinson's start in the GI tract with constipation 20 years before the symptoms of tremors occur. Okay. And so that's a very important fact. Also, they've picked up that the proteins that are not working are actually it starts in the gut. So we are coming out. There is data on fecal transplant and Parkinson's. I'm happy to report we're going to be doing some studies with an academic center on Parkinson's and fecal transplant. My own protocol of familial fecal transplant and Parkinson's is out there. I'll tell you a funny story. I had a patient that had a genomic test, and she had her symptom. I didn't know anything about the patient. I did a microbiome testing on the patient. And I said to her, I said, it's funny, you have a signature microbiome for Parkinson's. And she said, you're the second person because on my DNA, they said the same thing. And I go, well, do you have Parkinson's in the family? She goes, actually, my father had Parkinson's. And I go, well, what symptoms do you have in GI? She was constipated.
Well,
Did I intercept this woman to have Parkinson's before she became Parkinson's? So this is obviously the goal, right?
yeah.
Understanding who has Parkinson's, that's an observation, right? Because I don't want to, in a world where there's misinformation everywhere, I want to make sure everybody knows this is an observation in my lab in a patient. So is this the beginning, right? Because medicine science starts with this N of one, where you see,
Yeah. Right.
something, and then you go, wait a minute, I got to go there. So that's it.
Well, I'll tell you another Nobel Prize for you if you get any insight on Parkinson's, because this is a horrible condition, and one of those ones that I find to be a vexation in my life personally. Last thing I have for you as I'm watching our time here, I do want to ask. Okay, so you're talking about healthy microbiomes, healthy bacteria living in your gut. How do we people out here who are not doing fecal transplants on a routine basis, how do we develop a healthy microbiome in our GI tract so we can avoid some of the maladies that you're linking here with dysbiosis, I guess. So
Well, you could
go
join
for it.
you could join our research where you basically sign a consent. It's a 29-page consent. You get a stool kit
Okay.
and you get a meeting with me afterwards. And basically we go over what my observations are on what I'm seeing. And then we do, some nutritional changes to see if that's improving you. So it's all in research, right? So all we can say so far is this is an observation and you're entering a clinical trial that's basically, supervised by a regulatory board to basically see what's going on in the microbiome. And then from there, make changes that we would naturally make as physicians, but following the microbiome. So every day I get emails or texts from doctors that are saying, is this probiotic good? Is this drink good? And all I can say to them is test it before and after. Now, the problem with testing is there's not that many labs out there that are actually validated, verified, and reproducible. So, because it's the wild, wild west, when I embarked in it myself, I didn't want to start my own lab. And I started it as a research lab because I felt it's not a consumer product yet. You
Yeah.
see all these labs doing these genetic testing of the stools, it's not accurate. And inevitably, people you know, they get flawed results, which changes their perception. So imagine you find a microbe, Bacteroides, and you're like, oh my God, I'm freaking out. I have Bacteroides, kill it. Right? You may not need to kill it. It's part of your personality, who you are. It may not be a bad microbe for you. So, this is why it's so important to work together with doctors in the research to see the data clearly. We're actually, Progenobiome is going to become, we join doctors to the Biome Squad, I like to call it. We're going to be putting on the Biome Squad all the articles that I feel are legit because unfortunately, because there is so much noise out there in the microbiome space, you don't know what to trust. My job is really to validate, right? So if a lab comes out and says, you know what, we found this marker for Parkinson's and they're right, I'm going to validate it. I'm going to say, you know what, independently, I found the same marker. Therefore, it's valid, verified, and reproducible. That article stays. But
Yeah.
if the methods are wrong, right? They use PCR. PCR is garbage. We all know that. We've seen that with COVID. It's a piece of the microbe. That doesn't tell you anything. That piece could be in other microbes, right? So it's really not sensitive. It's really not specific. It's useless.
Okay.
So if I use a PCR, it's not really giving me the idea of what's going on. So, the head of the National Institute of Standard was at the Malibu Microbiome meeting. So you missed him. You could have talked to him.
Yeah. Well,
One of the things he said, because he analyzed all those consumer products out there, he didn't analyze us because we're research and we're writing the data that's peer reviewed by my peers, GI doctors. And he basically said, consumer beware. And I have to say the same thing. We're in the wild, wild west. Consumer beware. Beware of the probiotics you're sold. Beware of the stool testing you're sold. That's one lesson we should all learn from COVID is basically do your homework, do your research, and see for yourself.
okay. So, Dr. Hazan, how do people find you out there? How can people communicate with you?
Progena PROGENABIOME.com. And everything's in there. Our publications in there, our podcast, your podcast be in there. So people can just like go in there. They can also read a book that I wrote. I don't know if you want to put it on the podcast,
Sure, I
but
do.
yes.
Oh,
So let's talk
okay.
shit.
Okay. All right. That's quite a
We'll
title.
say let's talk
Um,
shit.
okay. Yeah.
So why did I write it like that? Because I
You
want
probably
people
want
to
to get our
understand.
attention. So the
No,
name of her book
I
is
yes,
called, for those who are not watching this podcast, is called Let's Talk SH exclamation point T. Okay.
yes.
You can find that on Amazon.
Yes, it's on Amazon. It's available at Barnes and Nobles.
Okay.
It's pretty much available everywhere. I did that because I didn't want to call it microbiome. Microbiome is sugarcoating a technology that's coming. We're in the fecal material in pills coming up. People need to understand microbes are what you see in your. And by the way, to bring back to God, how amazing the power of God to put the miracles of life, the answers of life in poop where nobody would touch it, right? And so if you go back to the beginning, this 5-year-old Sabine Hazan who asked God, where do we go after we die? And being brought to this, only to understand that when we die, those microbes in our guts, on our skins, decompose our bodies and put us back into the ground. The microbes are driving the planet. The microbes started before we started. That's the power of God. To put all of
I guess we're gonna end,
yeah,
we're gonna end our program with that, you guys. This has been an incredibly interesting conversation, Dr. Hazan. And again, her website is Progenibiome, Progenabiome, correct? Is that right?
yes.
And look her up. She is a fascinating woman. Her book is called Let's Talk. What was it again? I'm sorry. That it was okay. Let's Talk SH exclamation point capital T. Okay, you'll find it out there if you look for it. And Dr. Sabine Hazan, thank you so much for taking the time to be on my podcast today. It's been a pleasure having you. And friends, those listening, I want to thank you as well for tuning in. I hope this was helpful to you. Check in with Sabine. She's a genius, really, and she's on to something big in a different, many different areas of medicine. So Sabine, I wish you the best of luck in what you're doing. And friends, until next time, be well. Bye-bye.
You have been listening to the Hamilton Review, where kids and culture collide. Thank you for allowing us to be a part of your day. Tune in again next week on Apple Podcast. rate and comment, and tell a friend.